Okay, again, welcome to today's Transcend Professional Development Core didactic training titled Mental Health in Rural America. We are fortunate to have Dr. Stephen Wonderlich leading today's presentation. Dr. Wonderlich is the interim president for research in Sanford Fargo and the Chester Fritz Distinguished Professor in Psychiatry and Behavioral Sciences at the University of North Dakota School of Medicine and Health Sciences. He currently serves as the PI on the Center for Biobehavioral Mechanisms of Eating Behavior, COBRE, which is currently in phase 1 of funding. He has been continuously funded by NIH for over 25 years and has served as the PI on a variety of R mechanism grants over that time. Additionally, he served as the site PI on the Midwest Regional Postdoctoral Training Program in Eating Disorder Research, which is funded by the National Institute of Mental Health. The bulk of his funded research focuses on eating disorders, obesity, and bariatric surgery. He also served as the co-director of the Sanford Eating Disorder and Weight Management Center, which is a broad-based clinic and hospital program for individuals with eating disorders. He also was appointed to the American Psychiatric Association's DSM-5 task force, which created the current diagnostic classification for psychiatric disorders in 2013. Please welcome Dr. Stephen Wonderlich.
All right. Thank you, Kent. Appreciate being here and the opportunity to talk to you guys. So, Kent, can you hear me all right? And I'm good to go?
Yep, sound great.
Okay. So, Jillian, can you hear me? Yeah. Jillian, let's go to the next slide. Okay. So these are my objectives, but let me just say this. This particular talk's a little different than what I normally do. You know, I'm one of those clinicians, scientists, teacher people who has all kinds of ideas and theories and hypotheses, and I do tests of those concepts, whether it's describing psychopathology and psychiatric disorders or trying to treat them in randomized controlled trials or whatever we're doing. That's the kind of work I generally do when I'm doing scientific stuff in this space. This talk's a little different. This talk is about, in my mind, it's largely kind of the bloody obvious. And that is in our area, in our region, and in other states like ours, mental health kind of lives in a bit of a desert. It's really difficult to make sure that the people in our states are receiving good, solid, immediate mental health care. And I want to kind of highlight that and talk about a little bit of the implications of that situation, what it means for our state, and give some clinical examples, and hopefully just kind of give a high level overview of mental health in rural America and the challenges and opportunities we have looking at us. So I will start out with a quick review of mental health and mental disorder concepts, which I'm going to tell you right now is totally flawed, but I'll do it anyway, and then I'll apologize. And then I'm going to talk a little bit about data in our region, which is challenging and difficult. And then I want to wonder out loud, why is it so hard to do mental health care in rural America? Next slide, please. Okay, so here's, Kent mentioned, I was in diagnostics and taxonomy and classification. That was an area of research I did for a while. And so, you know, this idea that we have two states in front of us, mental health and mental disorder. I'm going to read them, and then I'm going to just kind of talk about what I think the problem is. Mental health is defined as a state of well-being in which every individual realizes his or her own potential, can cope with normal stress, can work productively, fruitfully and is able to make a contribution to his or her community. It's a very nice idea. It's a very nice concept. And I try and be in that state as much as I can. But then there's the other side, and that's mental disorder. Health conditions involving changes in thinking, emotion, behavior, or generally a combination of these. Mental disorders are associated with distress and/or problems of functioning in social, work, or family activities. The diagnoses, the problems that we encounter: depression, anxiety, schizophrenia, bipolar disorder, PTSD, addiction, eating disorders, many, many, many more. The DSM-5 has been criticized for creating too many psychiatric disorders over time. And I don't think it's because people just want to create them. It's because we're trying to capture the experience of people in our world. Here's my problem with this dichotomy. It's not, I'm going to use a little research language. This is not a between persons difference. It's not like there are those who are mentally healthy and those who are mentally disordered, and never the two shall mix. They mix all the time. This is dimensional, it's not categorical. And one of the biggest criticisms of psychiatric disorder diagnoses is the categorical system in the DSM-5 doesn't really get it. And dimensional models are a little too complicated. So all I want to say about this is most of us are hopefully going to occupy both of these spaces at different points in time. And when we are in the mental disorder space, hopefully it's not too significant, too impairing. But the truth is, as you'll see, a large number of us struggle with both sides of this coin. Next slide, please. Okay, and then, you know, what causes mental disorders? There have been various new solutions, new answers, great discoveries over time, and they're all valuable and they all add to our list of possible determinants. The biopsychosocial model of mental disorders is, I think, the only one that even begins to work. And that is, there's a lot of things. The personality of a person, that is the way they adjust, adapt, manage the world routinely. Environment, what kind of world did you grow up in? Was it violent? Was it not violent? Was it loving? Was it compassionate? Economic factors. People who live in really tough economic worlds have really different experiences and different risks for mental disorders. Social-cultural factors, eating disorders, where I spend a lot of my time. Even though there's really significant genetic contributions to eating disorders, there's also phenomenal studies which have shown basically that there are tremendous differences across different cultures for the risk of developing these very serious conditions. Psychological factors, simple things, depression, anxiety, etc., contribute largely to other mental disorders. And then, the genetic and the biological, the brain-based understanding of mental disorders, thankfully, is in the mix, but it's a portion of the mix. So it's complicated, and many of these things interacting together help us to understand mental disorders. Next slide, please. A few case examples. I'm an old clinician, so I just have to make it real. So here's case number one, 45-year-old male working as a car mechanic, divorced, one child who's a 15-year-old male. The patient has a history of depression, recurrent, and substance use disorder, which has remitted. First depressive episode about age 17, 12-month duration in that episode. It was combined, as is almost, well, not always, but often the case, very significant anxiety accompanying the depression, treated with antidepressants by a pediatrician and later a primary care doc, had two recurrences at age 24 and 36, which is typical. Had limited stressful life events, so not a really traumatic history. His marriage was negatively impacted by depression and ultimately was divorced at age 37. He's been in periodic medication trials. Psychotherapy's been added, which he tends to drop out of early. Currently living a relatively social, isolated life, is working and generally dissatisfied with the quality of his life. Next slide, please. Case 2, 23-year-old female, single, never married, part-time employment in a retail bookstore, had a history of anorexia nervosa that began at age 14, had concurrent obsessive compulsive disorder. Hospitalized for eating disorders for 2 months, discharged on antidepressants, referred to an outpatient eating disorder treatment program with a dietitian, a psychologist, a physician assistant. Significant concerns by and for the family. They were included in her treatment. There was improvement in weight, but ultimately she developed binge and purge behaviors, purging meaning vomitive laxatives, diuretics, diet pills, enemas, suppositories, excessive exercise, many strategies to try and rid oneself of calories. Significant weight gain and depression over time, which was very difficult, in and out of mental health care over the last 5 years. Suicide gesture at age 21. It wasn't a lethal attempt, but it was significant. Currently lives with a sister who, in the patient's words, keeps an eye on her. Next slide, please. Case 3. 36-year-old single male, unemployed, was a socially isolated, shy teenager. At 18, he began to have experiences with significant agitation and marked cognitive and perceptual events, seeing things, hearing things that seemed unusual to other people. He had very significant worry and anxiety about people taking advantage of him, kind of a paranoid stance, if you will. Emotional states were highly variable depending on kind of social and cognitive functioning. Hospitalized for a psychotic episode early in life, discharged on antipsychotics with a differential diagnosis of schizoaffective disorder versus schizophrenia. Currently receiving supportive care at a regional health service center, medication management, and cognitive therapy. So you get a wide range of just case material, the kind that in a mental health clinic, this is every day. Next slide, please. Now let's talk a little bit about North Dakota. It's a little dated. I've been doing some other things, so I haven't been able to keep up on this as much as I'd like. But back in around 2020, about a quarter of North Dakota residents met criteria for a mental disorder or a substance use diagnosis. That's not had little symptoms, that's fully meeting diagnostic criteria. In 2016, it was estimated that 30% of North Dakotans engaged in significant problem drinking, third in the US. I remember very distinctly years ago, North Dakota was the only state in the Union that had 2 cities with really elevated binge drinking rates, and the cities were Fargo and Grand Forks. In 2015, 137 North Dakotans died by suicide in the state. It is the second leading cause of death in teenagers and young adults. From 1999 to 2016, North Dakota had the largest increases of all the states in death by suicide. 58% increase. I mean, I always pause when I say it because, it's just a data point. But that's a remarkable statement. About a fifth of all youth aged 0 to 17 in North Dakota have experienced at least 2 significant adverse childhood experiences which are linked to mental illness and substance use. And that is child sexual abuse, child physical abuse, extreme child emotional abuse, or neglect. It's possible you could have a very serious car accident and be included in this group. It does increase your risk. But all of those childhood adversities have been shown unquestionably to increase the risk of a variety of mental disorders. And for those of us that like attributable risk analyses in longitudinal work, it's really, really compelling. Next slide, please. So now let's just take a look and we'll just highlight a few things. Different colors for different states, depending on suicide rates in that time span that I showed you a minute ago, 1999 to 2016. Wyoming had the highest rate. South Dakota was eighth, quite high. I already told you, North Dakota had the greatest increase in completed suicides. And what you see is something kind of that blue block in the central part of the northern US. That's where a lot of this was growing. And you'll see that subtext under the heading 6.1 times faster in rural areas. So rural America and suicide are related. Next slide, please. Now, this is not the greatest data in the world, but all of our kids, I didn't take it when I was a kid, but the Youth Risk Behavior Survey is a thing that kids take every year. And I stumbled upon this, and this is North Dakota data. And this is just over time from 2007 to 2015, increases in the endorsement of particular items. The blue one, I seriously considered attempting suicide. The red one, I made a plan about how I would try and commit suicide. The green one, I attempted suicide. Now, look, I used to work in a clinic with teenage kids. If a kid came in and they took a comb to their wrist, it was a suicide gesture in our world. Now, some of these examples that are being reported here are probably not the most serious or potentially lethal, but the fact that kids are talking about these kinds of behaviors and it's growing over time and it hasn't changed. In fact, it's increased, are really, I think, something for our state and us to think about. Next slide, please. Now, so what I'm saying there is, yeah, we got a little problem here. And do we know we have a problem? Next slide, please. The Center for Rural Health at the University of North Dakota does this needs assessment in critical access care hospitals across the state every once in a while. And they get a bundle of communities and basically ask the leaders of those communities in those hospital systems, what are your biggest needs? And this one is 2020 to 2022, but I went back, I think it was 3 cycles of Center for Rural Health's needs assessment. Mental health and substance use were the top two. So people living in these communities, in these hospital environments, know that this is a huge problem in our state. And we'll get to it. It's not just that we have a lot of mental disorders, we don't have a lot of resources to deal with it. We'll get to that. Next slide, please. And that's exactly what I'm saying here. We have a resource problem. Let me show you this. Next slide, please. This is kind of like that suicide change slide. Percent of US counties without any mental health providers by census in 2017. The light blue in the middle is the West North Central, which had the highest rate of counties without any mental health provider in them, 20%. 48 out of 53 counties in North Dakota are mental health shortage areas. I'm going to show you some data to that effect, not just for North Dakota, but for our surrounding states. But the point is, it's different. I mean, there's other places, West, South, Central, which I think is purple. They're at 14%, but the bottom line is in this central corridor, especially in the north of the US, mental health providers are not easily found. And if you're in one of these counties and you have a psychotic episode, somebody better call the police because there's not much else for you. And by the way, down at the bottom, mental health providers, psychiatrists, psychologists, social workers, psychiatric nurse practitioners, and counselors. There's nobody in 20% of our counties. Next slide, please. This is North Dakota, and this is the data on mental health professional shortage areas. And I'll show you 3 different states. North Dakota's, I said 48 out of 53. I think this supports my math. Cass County, Grand Forks, Minot, Bismarck, and Mandan. That's where we have people, providers. The rest of the state, not so much. And when we opened our eating disorder program in Fargo, believe me, we had people come into our hospital program from all over the state of North Dakota, and that program now is receiving people from all over the United States because there aren't many options for people with these kind of serious eating disorders. Let me show you another state. Next slide. This is South Dakota. There is not a county in the state that is not a mental health shortage area. I grew up in Minnesota. Let's look at that one. It's different down in the metro, but it's no different. We used to call it in-state and outstate, and there's a competition there, and it's a rivalry. Outstate is basically everything in blue, dark blue. In-state is the light blue. And there's a significant difference there. And Northwest Minnesota, Northern Minnesota is basically built a lot like the Dakotas. Next slide, please. So there is a struggle about mental health delivery in rural areas. And I want to just take a little time and think about that. I'm going to play a video or two just so you don't have to listen to me all the time. I want some other people to talk about this from a more personal perspective. But let's just take a look at this general struggle. Next slide, please. This first video is, I think, rather compelling. And I just want you to listen to it. It takes about 4.5 minutes, I think. Go ahead, Jillian.
My name is Jeff Winton, and I am the founder and the chairman of Rural Minds. I was raised on a family dairy farm in Chautauqua County, New York. I'm from a long line of dairy farmers. My father was a dairy farmer. My grandfather was a dairy farmer. Life on a farm is one filled with extreme blessings, things that I'm incredibly grateful for, but there are also hardships. Many people that don't live on a farm think of the beauty and the bucolic nature of a farm, and they romanticize what it would be like to live on a farm. But underneath that facade, in many cases, there are struggles and there are hardships. You're taught from a very young age to be independent, to pull yourself up by your bootstraps, to be self-sufficient, and not to talk about your issues. And certainly mental health is one of those things. Rural Minds is a result of a family tragedy that happened in my farming family. My nephew, Brooks, who worked on the family dairy farm, by all measures, he was the life of the party. He was a very happy, very gregarious young man who had friends from all walks of life. One day, as I was leaving the wedding reception for his brother, Brooks gave me a big hug and said, "Uncle Jeff, thank you so much for everything you've done for my family. And I didn't think anything of it because he was a very grateful, very appreciative young man. 2 days later, I happened to be driving past Brooks's house, and I saw police cars, I saw an ambulance, and I knew something terrible had happened. I jumped out of my truck, went running down the driveway, and the woman across the street grabbed me with tears coming down her face and said, "Jeff, don't go any further. I just found Brooks in the backyard of his house, and I think he's dead." And at that point, the world stopped. The coroner came, and his cause of death was death by suicide. He was the absolute last person that we would have ever expected who would have taken his own life. Clearly, he was suffering in silence. Because of the shame that comes with mental illness and suicide in particular, there was some question as to whether or not my family should even talk about why my 28-year-old nephew died. And it was my mother, who was a true matriarch of our family, tears coming down her face. She said, "Pastor, this is going to stop with my family. We are going to not only talk about it, we are going to start at Brooks's funeral, which was 2 days later." After that funeral was over, we had other farm families lined up to tell us their story. Because of my mother's bravery and her honesty, other farm families felt, well, if the Wintons can talk about this, then we can talk about it. And all of a sudden, the floodgates opened, and this movement started. Rural Minds is the only national nonprofit organization that is focused on mental health equity for the 46 million people that live in rural America. We have designed programs that are specific to people in rural America, and also taken other resources that have been designed by other organizations and gotten them in the hands of the people that we represent.
If I could tell Jeff what it means to me, I would say it's a lifeline. It's a lifeline. It's powerful. It's life-affirming for me to know that there are people who care about this person that I love so much, and he's changing how mental illness is looked at in our communities, and he's changed it specifically for my family. I'm so thankful to him for being a voice for all of us when we didn't always have one.
It's estimated that young people that live in rural America are 74% more likely to die by suicide than young people that grow up in urban and suburban areas. Another estimate I've seen is that farmers are 3.5 times more likely to die by suicide than any other occupation. That's tragic and that's heartbreaking. But there is help and there is hope, and that's the role that Rural Minds is here to play.
What would you tell Brooks now?
Well, first I would tell him that I love him and that I miss him and that life hasn't been the same without him. In a way, as much as I miss him every day, I feel his presence because I'm doing what I know he would want us to do. I'm proud that people that we represent have a place that represents who they are, that reflects who they are, that understands who they are, and someone who is going to help them.
Okay. Clearly, contextualizes the data point, and helps us to really grasp what suicide means to our communities, to our families. And I'll say this to clinicians, working in the mental health sphere for a long time, toughest thing I think we always had to deal with was when people would die by suicide. So a real challenge. All right, so this is a group that has tried to develop a model of what are the primary factors which sort of get in the way of receiving mental health services for rural communities. And we'll go through these, but the three things: acceptability, availability, and access. Very important. We'll take a look at each of those and just think about it a little bit in terms of rural life. Next slide, please. So accessibility. Individuals with mental health problems live in geographically dispersed areas, have limited access to mental health services due to simple things. Getting there. It's not like being able to get on a subway in a city and go downtown for my mental health appointment. If you're driving 4 hours to get to a mental health appointment, it's a challenge. And I don't think I need to, describe this in any great detail, but geography and weather matter. I mean, I remember when we'd have blizzards and my patients would cancel, and I may not see them for 10 days to 2 weeks. You just hope they come back. Limited or absent broadband connectivity, probably a little better now than when this was originally published. But to the extent that we're ultimately going to rely on some kind of technology to bring the providers to the patient, if the patient can't get to us, we got to get to them. And how do we get to them in a way that matters and works? Interesting things have happened with telehealth and digital technology. In the 90s here, we did one of the first telehealth treatment trials comparing telehealth delivered eating disorder treatment to in-person eating disorder treatment. And the take-home message, and this was back in about 1999 to 2000 that we actually published the data, there was no significant difference in outcomes between telehealth and in person. I think it's the way of the future. Next slide, please. Acceptability. Social stigma and mental illness. I mean, come on. We all have it. And it's a challenge sometimes to sort of embrace the fact that we might have some sort of a significant psychiatric condition and we need to seek care. 2006 study found that stigma concerns were higher in smaller towns, in rural communities. Importantly, and this actually, there's a lot of new data on this. Studies show that rural residents wait longer to seek mental health care and enter treatment, and then have more serious symptoms than their urban counterparts. The early intervention work across various psychiatric conditions is clear. The sooner you get in and get something treated, the more likely you are to have less severe relapses. So waiting is not a great solution. Next slide, please. Availability. As we talked about earlier, more than 85% of federally designated mental health professional shortage areas are in rural communities. Due to the shortage of behavioral health specialists, primary care providers basically become kind of the ad hoc behavioral health professional, even if they're not equipped or trained or comfortable with that role. It's just part of the deal. And many of my primary care colleagues in rural settings have talked to me and others about this. It's a challenge. And when you're running 7 to 10 minute appointments and you got a suicidal person sitting in your clinic, it's a challenge. It's not a great fit. Next appointment, or next slide, please. So a few ideas that might be useful for rural areas. Let's just go through these, nothing groundbreaking. Number one, integrating behavioral health and primary care. And certainly in our Sanford space and in many other spaces, this is becoming increasingly sought after. Primary care is the de facto mental health care delivery system for many Americans. Bringing mental health providers into primary care clinics, it's challenging and it's complicated, but at least trying to find some way to marry the two, I think, is one important strategy. Next slide, please. Leverage various forms of digital and other types of technology. It's going to just kind of remove some of the transportation barriers. And with some of the newer things, and I talked to Susan Berry, who's really kind of heading up a big chunk of the new digital hospital down in Sioux Falls. There's a lot of things that Sanford is doing to try and provide more immediate access to providers, letting people be seen and treated in their homes or certainly in their rural communities using some of the technology we now have. Hopefully, its acceptability remains high. Next slide, please. Grow our own behavioral health workforce. The lament of rural towns. We have to send them away to get trained and then run the risk that they won't come back. In North Dakota, we have one psychiatry residency program. We have one clinical psychology training program. I'm happy to say we now have a clinical psychology internship and fellowship program. The more that we have opportunities for young professionals to get their training in our states, I think the better chance we have to retain them and be able to incorporate them into our professional groups. Next slide, please. Increase collaboration with community partners to focus on prevention and recovery. All the different pieces of our communities, the faith community, a lot of people basically would go to a church before they'd go to a mental health clinic. Having a pipeline there is important. The schools, it's vital that we figure out how to do it. We tried to do a pilot study about 10 years ago using telehealth and piping professionals from Sanford Behavioral Health into local schools. It really went quite well. The problem we had was we just couldn't find enough providers to manage that and maintain access to our clinics. Law enforcement and first responders goes without saying. And the one thing I'll say too, both law enforcement and first responders are people that we need to think about too, because a lot of times they're entering into situations which are extremely complicated. One of my secondary interests is post-traumatic stress disorder. And a lot of these folks that walk into extremely risky and dangerous situations struggle themselves. Social service agencies and mental health clinics need to be tied together. We need to be better integrated and more collaborative and connected. Next slide, please. Now, I'm going to show you one more kind of goofy little video, but it makes a case for a system on the East Coast in northern Pennsylvania and southern New York, and kind of an integrated system for mental health care and how they've started to figure out ways to connect different systems, different institutions to provide more integrated care. This is only about 2 minutes long, and then we'll take some questions.
It's too much. I can barely move. My anxiety is worse than it's ever been. Living in rural Allegheny County, seeking treatment can be very difficult. I call the local community behavioral health clinic, and they say the next appointment is in 3 months. That won't work. I need help now. So I go to the emergency department. There aren't any psychiatric providers at this small community hospital. So I waited for hours. Then I was evaluated only to be transferred an hour and a half north to a larger hospital. The psychiatric emergency department is packed. There's shouting and people running while I'm waiting for hours again. And now they're saying I don't fit the criteria for inpatient psychiatric admission, like most people transferred from smaller hospitals. It's been 24 hours and I haven't received any of the care I need. And I'm being discharged, put in an ambulance, and sent all the way back home. Susan and rural residents deserve better access to mental health care. The digital web solution connects rural communities with additional support in a cost-effective way so individuals can receive the level of care they need where they need it. Now, the local therapists, the local hospital, and the larger hospital work together for on-site psychiatric engagement, telepsychiatry, and telementoring, so that Susan and others are connected to the mental health care they need.
Okay, I think that's it. Next slide, Jillian. Yeah, in summary, mental health problems are significant in the Northern Plains. Mental health treatment is limited by available providers in much of the tri-state area. Solutions for mental health treatment in the Northern Plains rest on collaborations in healthcare and communities, along with technology. And I think it has to be both. It has to be people connecting with people and then using the technology creatively. Thank you for your time and attention. Happy to take any questions.
Steve, thanks. That was great. Can you say a little bit about a certain subpopulations such as LGBTQ in more rural areas and their risks, and other marginalized groups that may actually have even a more difficult time than their colleagues in urban areas?
Yeah, thanks, Andy. I'm not able to speak a lot to resources available, but just in terms of the risks of any sort of a marginalized group or a group who's facing kind of additional challenges on top of everything else. The question is just, I think, how does the community embrace and then facilitate connection to services? And I think that's a meaningful and challenging question for a lot of the people who are LGBTQ or whatever the situation is. How is the community trying to find portals of entry and support mechanisms for those folks? I think it's like minority and ethnic groups as well. It's a challenge that will continue to plague rural America.
See, Amy has a question.
Who does?
Okay. Sorry, I had to figure out. This is Amy Wermeyer. Hi, Steve.
Hi, Amy.
I had to figure out how to unmute. I'm on my phone, so sorry for the lack of video. I loved what you said about kind of growing our own healthcare professionals and thinking about behavioral health focus for our healthcare trainees. And that's an area of research that I've been involved with lately, and looking specifically at stigma of healthcare professionals toward behavioral health and substance use disorders, and how that has a tendency to detract healthcare trainees from going into a behavioral health focus or specialty. Any thoughts about how we can combat things like that? Things like our colleagues may be speaking somewhat derogatorily about our mental health clients, and then unintentionally often discouraging trainees from pursuing these kinds of areas.
Yeah. Um, well, the easy thing, Amy, is, education and trying to speak the truth a little differently. I think maybe the best way is to get some of us folks who have been living in the mental health community and we understand our own personal mental illnesses and go and talk about it. And if somebody wants to tell me that because I have a mental health diagnosis, I'm unsuitable or weak or whatever, I'm happy to have that conversation, but I'll have it directly.
Love it. That'd be powerful.
Kumi has a question as well.
Hello.
Hi.
Thank you so much for the great presentation. I was wondering if you knew any kind of a trend. I know that the farming community has kind of a tough mentality, and then they feel like they need to deal with it themselves. But then is there any tendency in younger population who are trying to make things better for them in terms of mental health?
Yeah, Kumi, I mean, it's a really good point. This sort of tough person mentality that was referred to in the video, and independence and autonomy, and I take care of my own issues, and I don't complain, I don't whine, I don't do anything. Yeah, I think that's part of not just rural America, but a lot of different sectors of America. The idea that hopefully younger generations are finding ways to broaden that perspective and help all of the people find ways to be more flexible and tolerant and accepting. I think it's certainly the goal. Now, it's not really my space. I haven't been in it much in the last decade, but what's happening in terms of broadening out those roles and sort of obligations and duties, and if in the younger set of people, is unclear to me. Maybe somebody else has some information, but I don't, in terms of is it working? Is it happening? Hopefully.
Thank you.
Uh, David?
Yeah, hello. David Schmitz, Chair of Family and Community Medicine here at UND. Thank you for this presentation on such an important subject. From a family medicine perspective, I just wanted to support your statement with regard to how we can do things better as a team with adequate mental health resources. For the last 15 years or so, we've been doing some research known as the Community APGAR Project, where we look at the ability of a community to retain and recruit and retain certain providers like family physicians to critical access hospitals. We've been doing this work across the United States. I just returned from West Texas, and we've done this work in North Dakota as well. And amongst the 50 factors for recruiting and retaining like family physicians to rural health clinics or critical access hospitals, the availability of mental health professionals other than the family physician to be part of that solution, the availability of telehealth, telemental health, and also what we consider sort of the commensurate burden of providing mental health in an isolated rural environment are all weighed with regard to the cost of recruiting and retaining family physicians. And that's an expensive undertaking. As you may know, the estimated cost of recruiting a family physician and onboarding them is around $2 million to the community, can be several $100,000 direct costs. And so we often talk to hospital administrators and systems who ask, how can we afford it? To say, how can you not afford to integrate mental health as part of the team, especially for psychiatric emergencies? And so that's been something we've been able to share with health systems across these rural areas. And I do see where even in a state cohort such as West Texas, where mental health is one of the top needs of the 50 to recruit family physicians, that there are hospitals that are clearly positive outliers that have found a way and share those best practices, often through collaboration, through remote access to telehealth and immediate support, and sometimes, frankly, with on-site recruitment of mental health providers specifically. But when you mentioned the waiting room scenario, it's all too often that it results not only in issues with regard to meeting that mental health need, but also access needs for everybody else who needs to get back to work, and frankly, the economic needs that can offset some of those costs of the proper investment.
You just said it all, David. It is brilliant, and it's what we need to be doing. And somehow the systems are going to have to bite the bullet and decide, do we want to have an environment that helps us to keep our primary care providers, or do we want to burn them out and fry them? And I wish I could say, I hope they make the right decision. I hope they do. We'll see.
Thank you.
Gary.
Steve, thanks for a wonderful and poignant presentation. I have a couple of thoughts. It seems to me that the issue of access to psychiatric care is obviously a complicated one, but it's not unique to psychiatry or psychological services. Anybody who seeks specialty care in a rural area has a very, very long wait. The tremendous advantage, though, that psychiatric services have over, say, neurologic disease or, say, an inner ear problem is that you can actually obtain services in the privacy of your own home, given that your own data show that telehealth is as effective as in person. If you have Meniere's disease and need an inner ear specialist, you are really SOL. Because you're not going to find that in North Dakota, and you really do need to travel for that. So I'm wondering whether or not psychiatric and psychological services could take a page out of the book from some very effective, let's call them either telehealth or mail order health things. If you were an investor 5 or 6 years ago, you could have made a very good sum of money by investing in companies like Hims or Hers, which sell erectile dysfunction, blood pressure, and other items out of the privacy of your own home. And if you think psychiatric disorders have a bad vibe, no, men don't like to talk about their erections or lack thereof. And the reason that these companies have done so well is that they enable you to do that from home. And nobody has to know about it because they can provide the same services that a family health doc can do. So it seems to me, or a urologist or a gynecologist or any number of specialists, which are much harder and much more expensive to access, and because they're rare. I'm wondering whether or not the issue here is one of communication and marketing. The idea that there isn't shame to having anxiety, depression, suicidology, any number of these things, and you could get help through a variety of mechanisms. It seems to have worked in another area where sort of intimate care is provided, and it's provided, I think, effectively and certainly economically.
Yeah. No, it's a very good point, Gary. I get it. The one problem, I mean, so if AI comes up with an agentic voice that can cure depression, we got our solution. But there's still only so many providers in the state, and even if they're being piped into people's homes on telemedicine, it takes them out of the clinic, and then access into the clinic in person is decreased. Bottom line, I think we just need more providers. I checked a few years ago, 94% of all the degrees in mental health in North Dakota are in social work and counseling. And that's good. It's good because those folks can do a lot of good and a lot of help. But we have very few psychologists and psychiatrists in the state.
Steve, we have a question in the chat. It says from Nathaniel Johnson, we have heard about people getting hangry, denoting the link between dietary intake and mental health. What role does limited access to food in rural settings play in mental health differences between those in urban versus rural areas?
Well, I can speak to at least a piece of that, and food insecurity, absence of appropriate amounts of reasonable food, seems to be associated with a variety of mental health conditions and contributes. It is one of those environmental factors which can increase risk. And certainly in the area of eating disorders, we know all too well what starvation does. And so it's certainly a point to think about, and making sure that families and kids can eat is a good thing, period.
And we're wondering, will you be sharing your references or the slides themselves?
Sure. Yeah.
And we could probably post them on the Transcend website.
Yeah, that's fine. We good, Kent?
I think are there any other questions? I'd like to thank Dr. Wonderlich for the presentation today. And thank everybody for attending today's didactic training. I do want to put a plug in for the next one though. On July 21st, Dr. Mark Williamson will be presenting Power Analysis Made Manageable. So if you want to mark your calendars for that one, we hope to see you there. Okay, well, thank you, everyone. Bye-bye.